Well, I understand that many of your patients have come in that have already had back surgery. So how does treatment of those patients begin if they've already had the back surgery?
In the same way in some ways, but it's a little different. When people have had previous spine surgery, we typically start from the beginning again. What were your symptoms? When you look at the statistics or the results of spine surgery, say for instance you have a disc herniation and have pain down your leg, and that's really your biggest problem. Nationwide, even in average hands, the success rate's pretty good, 85% chance, maybe even a 90% chance that you will be satisfied with that surgery. And those are pretty good statistics for spine surgery. But that does mean that there's 10% of people who have had a surgery who aren't any better. And that doesn't sound like much unless you're one of them. But when you talk, of the hundreds of thousands of spine surgeries that are done each year in the U.S., with time, that adds up to quite a few. So people who've had previous spine surgery typically have complaints or problems that may or may not be related to their previous surgery. It may be a different problem. So one of the things we do when they show up is we ask them, what was the surgery for? What problems did you have? Was it your back? Was it your leg? Things like that, because it's real important to pin them down about their problems.
Yes, that was going to be my next question. How in-depth do you go when looking at their previous procedures? Do you talk to their surgeons, their previous physicians?
Sometimes I do, particularly if I can't get the information from the patient or an MRI. It's real important, even with people who have not had previous spine surgeries, it's like a verbal contract. Doctor, this is my problem that I want you to fix. What you don't want is to fix only part of their problem, if it's possible to fix both their problems. Or sometimes you negotiate. And what I mean by that is a patient has a deteriorated disc in their back. We all sort of know what that causes, back pain. They have back pain and leg pain, but they really don't think the back pain is a big problem. They really want the pain down their leg to get better. Treatment for that person with a surgery would be different than somebody who says, my back hurts much more than my leg. And that's one of the failures of spine surgery, is that sometimes what the patient wants the doctor to fix and what the doctor fixes is not the same thing. And I think sometimes there's a communication gap. And so it's real important to me I use the magic wand question a lot. And, an example would be, so if I had the magic wand and I could make your back pain better or your leg pain better, but not both, which one would it be? And sometimes they'll say immediately, within a nanosecond, it's my back. Or within a nanosecond, it's my leg. And then sometimes you get this long pause where you know that it's both, because it's clear that that's what the answer is. Clarifying those things really does help you direct the treatment that way. So one of the things that's important with patients, even patients who have not had previous spine surgery, is to see, because it's a pain problem usually. Other than the neurologic crises where they could get crippled or paralyzed, we're dealing with pain as a rule. It's important to decide what bothers them the most. So once you're done with that, then you do a physical examination, and that can be helpful. Whether they have scars, did the scars seem to match where their problem was? Do they have any other musculoskeletal problems? We call those masqueraders. A classic example is you could have, say, buttock pain, fanny pain, pain in your thigh, pain in your groin, maybe even some pain in your calf. Had a disc surgery and not any better, only to find out that you have a hip problem. And the same thing's true with having neck problems and shoulder problems. The symptoms can be so close that sometimes, and you can have both problems, okay, or appear to have both problems, and have surgery for one when the other may be as much of a problem. So the physical exam sort of helps with the masqueraders, we call them, the spine masqueraders, things that act like they're a spine problem that they're not.